Good morning, everyone. I'll be presenting on touch and die on behalf of Medicine 3. Mr. S, a 39-year-old gentleman from Assam, who's a farmer, came with complaints of back pain for 1 month, muscle twitching in both the lower limb for 1 month. Coming to the history of presenting illness, patient was apparently normal before 1 month, and then he developed back pain and cramps in the calf muscle in both the legs, and also occasional cramps in the thighs. The pain and cramps are worse on changing position and subsides in a minute. This is associated with twitching of the same muscles which lasts for a longer duration, sometimes continuous. No other significant history. No history of rash, no other joint pain. Excessive sweating is present. Occasional palpitations present. Patient feels anxious. So complaints of ulcer noted in the right lateral border of the tongue for the past 10 days. There is no associated pain or bleeding from the ulcer. There is complaint of loss of weight for 45 days, significant weight loss 60 kg to 45 kg. There is history of dental caries present. So coming to the past history, patient had a history of hydrocele aspiration and injection 3 months back, and history of intake of Ayurveda medications for left knee pain for 3 years till onset of his symptoms. History of using tobacco for the past 10 years, and patient doesn't have no other comorbidities. So coming to the examination, vital says the patient had postural hypertension, no pallor, icterus, cyanosis, clubbing, pedal edema, or lymphadenopathy. Cardiovascular system wise, normal. Respiratory system and abdomen were normal. Coming to the central nervous system, higher functions were normal. Cranial nerves were normal. Motor system power is 5/5. Sensor system, there is no sensory loss. Reflexes were 2+ in all the 4 limbs. Muscle twitches are present in the bilateral calf muscles, spontaneous, coarse, and rhythmic. No association with stretching, present only in calf muscles and not on other muscles. Tongue ulcer, it's ulceroproliferative lesion of size 1 centimeter in the right lateral border of the tongue with everted edges. Necrotic tissue at the base, induration of 0.5 centimeter around the ulcer. No cervical lymph nodes are palpable. So this is the video of the facet muscle twitches that we saw. What are all the differentials would you?
Just open this if it's not coming. This is getting.
So what are all the differentials considered? So the actually patient has myokymia. Myokymia is the fibrillation of the muscle contraction, and it affects only the single muscles, and it is most commonly seen in the facial muscle, that is eyelid. It is common in all the peoples. It is most commonly seen in people who are more intake of caffeine or stress or exercise. The patient had myokymia. So the differentials we considered were syndrome complex. The patient has back pain with myokymia, loss of weight, autonomic dysfunction, and neuropsychiatric involvement. So the differentials considered were peripheral nerve hyperexcitability, paraneoplastic cause was the first thing we thought of, and second thing is thyroid disorder, and the third one is motor neuron disease. We didn't think of because the lower motor neuron involvement, that is weakness, is not present. And also myokymia, there won't be any associated weakness, whereas in fasciculation, the patient will have associated weakness in lower motor neuron involvement. So investigations wise, HB was 14.1, WBC was 15,400, neutrophils of 76 and lymphocyte of 13, platelets was 2,27,000, sodium was on the lower side 16, 116, and the thyroid was normal, cortisol was also normal. So with the serum osmolality, urine spot sodium and urine osmolality, the patient had SADH, magnesium and other electrolytes were normal, LFT and creatinine were normal. So we did a nerve conduction study which came back as normal, and we also did anti-VGKC antibodies which came back as positive. So this coming to the myokymia, the myokymia can be this presenting in three features. It can be facial, regional, and generalized. The patient didn't have any facial myokymia, so we excluded that. The patient had regional myokymia, which is more commonly seen in myelopathy, radiculopathy, plexopathy, and mononeuropathy. However, the patient didn't have any other features of lower motor neuron weakness or other features. And also MRI spine we did showed only the degenerative changes with no compression. And this generalized causes, we have this peripheral neuronal hyperexcitability syndrome, Isaacs and Morvan syndrome, and hereditary diseases, acquired demyelinating neuropathies, and toxic exposures and thyrotoxicosis. And the EMG we did was normal, so we ruled out this demyelinating neuropathy, hereditary diseases. And the TSH was on the normal side, so we ruled out this also. The two things we thought of was PNH syndrome and the toxic exposures. So coming to this peripheral neuronal hyperexcitability syndrome, it has three: this cranial fascicular hyperexcitability syndrome, Isaac syndrome, and Morvan syndrome. These are the features how we differentiate these three syndromes. In all these three syndromes, the male preponderance is the males are most commonly affected, and the patient has cramps or fasciculation, or patient had cramps and as well as the muscle twitches. So we couldn't rule out all these three. And also myokymia, the patient had, which is not present in the CFS. So we thought of Isaacs and Morvan. And the dysautonomia was also present. Our patient had postural hypertension, tachycardia, and occasional anxiety. So we thought of again Isaacs and Morvan syndrome. This CNS dysfunction in the form of neuropsychiatric manifestations were present in our patient. So we thought of Morvan syndrome. So in all these things, cancer is most commonly associated with the Isaacs and Morvan syndrome. And as the neuronal antibodies also for our patients is positive, anti-VGKC antibodies was positive. So here we can see this in the peripheral nervous system involvement, only the CFS is involved. If there is autonomic involvement, it is Isaac syndrome. If there is central involvement, it is Morvan syndrome. So our patient was diagnosed as Morvan syndrome based on these features. So coming to this VGKC antibody, this is a voltage gated potassium channel. It helps in the repolarization and stabilization of the resting membrane potential. If there is an antibody to it, the patient goes into sustained depolarization. So there is muscle contraction causing the muscle twitches. So coming to the Morvan syndrome, so incidence is more common in the male in the ratio of 19:1. The causes of Morvan syndrome is heavy metals poisoning like gold, manganese, mercury, and elevated cerebrospinal fluid as IgG and oligoclonal glands, and thyroid toxicosis or autoimmune hypothyroidism, clinical or subclinical myasthenia or neoplasms like thymoma, small cell lung cancer, teratoma, prostate adenoma, and carcinoma in situ of the colon, and scrotal manipulation. So for our patient, because the patient had a tongue ulcer, we did a biopsy. It showed epithelial hyperplasia with focal ulceration and subepithelial moderate chronic inflammation with no evidence of malignancy. We also did a PET CT to rule out unknown primaries. So it also didn't reveal any occult malignancies. It only revealed subcentimetric right level 3 node, which was considered to be insignificant. So coming to the clinical presentations of this Morvan syndrome, the feature most commonly, this is the study done in study which included 29 cases of Morvan syndrome, and they categorized the patient who presented with the following features. So the Marfan syndrome, the patient had associated tumor in 11 of them with the following antibodies and myasthenia gravis, and there is associated weight loss, delusions, myoclonus, change in mood, serum hyponatremia, hallucination, anxiety, agitation, confusion, and disorientation. So our patient had weight loss, serum hyponatremia, anxiety, agitation, and cramps, that is pain. So this is the course of the disease. The patient had complaints only for 45 days. So our patient is in the range in this starting stage of the disease. As the disease progresses, the symptoms also worsens. Initially, the patient has hyperhidrosis, itching, muscle twitching, and weight loss. As it progresses, it starts to have hallucinations, insomnia, incontinence, and sleep disturbances. And at some point of time, the sleep improvement in sleep will be there, and disappearance of hallucinations. So after that, it still worsens, and it finally ends in death in 2 years time. So how did our patient develop Marfan syndrome? So we thought the cause for the Marfan syndrome to be this hydrocele aspiration and this heavy metal poisoning. We ruled out tumor causes, and EMG was normal. We ruled out other neuropathy causes also. So our patient had hydrocele aspiration and injection 3 months ago. USG scrotum done here showed no significant abnormality. The patients with the patient also has history of Ayurvedic medications intake for 6 months for left ligament knee tear. So how the scrotal manipulation causes Marfan syndrome? So the antigens in the testis, it is usually contained within the testis. During this manipulation, the antigens come out, which enact an autoimmune reaction, thereby causing this autoimmune reaction, causing this Marfan syndrome. So our patient had an aspiration and injection, which could have elicited the autoimmunity process to have this Marfan syndrome. So our patient also had a history of alternative medication use, Ayurvedic medication. So we sent a urine 24-hour urine mercury. It was on the higher range. So 86.2, 88.6 microgram per 24 hours. Normal was in the range of less than 10. So plasma mercury for our patient is awaited, and the analysis of the alternative medication, that syrup the patient taken, the analysis is also awaited. So overall, our patient has features of weight loss, autonomic dysfunction in the form of postural hypotension, tachycardia, hypertension, hyponatremia, myokymia, neuropsychiatric manifestations, irritability, anxiety, and positive VGKC antibodies confirming Marfan syndrome. So management, our patient, if the cause for the Marfan syndrome is hydrocele, the inflammation is self-limited. In case of mercury poisoning, we should do a chelation and the steroids. So summary is we should be able to differentiate the fasciculation versus myokymia. Heavy metal poisoning in patients is common in patients with Ayurvedic medicine intake, and manipulation of scrotum should be avoided. Mercury can also cause autoimmune manifestation, and some info regarding this Marfan syndrome. Thank you.
Thank you, Brightlin. Questions from the audience?
How much is the chromium?
We've sent this heavy metal screen totally, when the report is awaited. You sent only this mercury specifically.
We had 2 cases which we reported from M3 only, which actually they've taken chromium as a part of the Ayurvedic medicine. And I thought, what is the relationship with the oral ulcer? Because the third patient we had used to actually chew the battery tops of the cell phones. He was a battery repairer, and because of that, he had an oral ulcer and he had chromium poisoning and present myokymia. So I thought you would link like that.
Okay.
What was your link? The oral ulcer? Because
there is no history of.
We also had a similar patient with BKGC antibody positive and myokymia who had taken alternative medicine. We actually lost the patient because we gave steroids. It's better not to give steroids. He developed overwhelming sepsis and passed away. So I think you should just keep it for.
Yes, ma'am. Sure.
Okay. Thank you. Thanks, Brightlin. And we'll move on to the next presentation from Medicine 4, Dr. Andrew Kevin, presenting on too much pressure.